So thank you all for joining this webinar. As I was just mentioning, everything will be on slide. All of the slides and video will be online very soon, maybe 1 or 2 days. Okay, so this is part of our ongoing series. We've had approximately quarterly webinars on various topics. You can find all of the previous recordings and videos and resources on the WHONET website. To find that information, you simply go to whonet.org. Here on the top menu, it says webinars. When you click on webinars, you'll see the previous sessions as well as today's session. And then within that, you can get the slides and the PowerPoints. I originally was planning this webinar to focus on 2 things, antibiograms and the new WHONET breakpoint tables, and I will cover both to some degree. I gave a version of this webinar approximately a week ago to the country Laos, and we filled 2 hours with the antibiogram, so I will talk to some degree about the new WHONET breakpoints, but to make sure we finish everything on time, the focus will be on antibiograms, with a few comments on the new breakpoint tables. Those are very important, and I'm happy to follow up later by email and other sessions for talking about the new tables. Broadly, we'll start off with the PowerPoint about antibiograms, their purposes, uses, objectives, some recommendations, and some examples. And that will be followed by how do you do antibiograms in WHONET, including some new features that many of you have not seen yet that we have introduced relatively recently. We will talk about many examples from the human health sector, but also from the animal health, environmental, and food sectors. I misspelled it, Janet Hindler within, I'll just go ahead and fix that right now. Many of the slides have come from our collaborators and good friends, Janet Hindler, for many years with UCLA and with CLSI, and to Jens Thompson for collaboration and also for slides used in this presentation. Part 1, antibiograms, introduction, recommendations, and examples. So a number of the comments will be taken from the CLSI M39 document. The title of this document is Analysis and Presentation of Cumulative Antimicrobial Susceptibility Test Data. I will show you the website later where you can find this document. Some CLSI documents are free. You can download and utilize those, or they can be read online. You cannot download them, but you can read them online. This is not one of those documents. So this is a paid document. It's cheaper if you are a member, and I'll talk a little bit about that later. There is another similar document called the VET-05, which is the same kind of document, but with the focus on analysis and presentation of data from the animal health sector. In both of these documents, they cover guidance on the collection, storage, and analysis of data, preparation of antibiogram reports, including both routine and enhanced antibiograms, and there's a specific primary objective of guiding selection for empiric antimicrobial therapy. We'll talk more about that later. There are issues about repeat isolates. Do you take the first isolate, the last isolate, average isolate? And there's not one correct answer, and it really depends on your objective. The M39 document's focus is guiding the selection of empiric antimicrobial therapy for patients who do not yet have their microbiology results. Data presentation, and some examples. The CLSI document focuses on cumulative antimicrobial susceptibility test data, the human document. The veterinary document does go into greater range of activities such as line listings, multi-drug resistance, scatter plots, his zone diameter or MIC histograms. But you see the M39 focuses on cumulative data for percent susceptible or sometimes percent resistant. The CLSI document defines what we refer to as a routine antibiogram, where the primary aim is guiding clinicians in the selection of empiric therapy for the initial infections when definitive susceptibility test data are not available, either because of clinical susceptibility, either because a sample was not taken, or because a sample was taken, but the results have not are not available yet. It always takes generally 2 or 3 days to get your antibiotic results. So when I refer to the routine antibiogram, the objective stated by CLSI is guidance for empiric therapy while you are waiting for results, if there are results. The second one, routine criteria, reports that do not meet these criteria. When you have a different objective, when your goal is not therapy guidelines, but identifying emerging resistance. So if you take the first isolate, that is valuable for empiric therapy decisions. But you might miss if a patient has a CRE, a carbapenem-resistant Enterobacterales, as their fourth E. coli, that particular isolate will be missing from the routine antibiogram from that patient. But sometimes you do want to make sure you include all of these isolates, even if they are not the initial one. So when the objective is identifying the emergence of resistance of rare phenotypes, then you may want to do what we can call an enhanced antibiogram. If you want to look at all isolates, if you want to look at general trends for public health surveillance, those are different types of antibiograms. And I also want to focus on another objective. The objectives on the left presume that you have good quality data. But an additional great value to antibiograms is trying to get an idea if the laboratory is having issues about quality of testing. Are they testing the correct antibiotics? Sometimes there are obvious mistakes. E. coli with vancomycin results. That's completely inappropriate. It is resistant. There's no reason to test it in the laboratory. Though it would be a mistake for you to test vancomycin on an E. coli. You can do it, but the result is going to be resistant. There's no reason to bother testing it. That's an obvious mistake. There are other mistakes that are not so obvious. For example, to find MRSA, methicillin-resistant Staphylococcus aureus, many people, what you are supposed to test is the oxacillin antibiotic by an MIC method, or the cefoxitin disc, the disc method. However, some laboratories test the oxacillin disc. That was recommended in the 1990s, early 2000s, but it was found to be a good test, but problematic, especially with regards to a certain subtype of Staph aureus. So if I see Staph aureus with oxacillin disc results, that's a mistake. You should not be testing the oxacillin disc. You should instead use the cefoxitin disc or an MIC test. Sometimes you see unexpected resistance. I've seen many clinical antibiograms where Staphylococcus aureus has 2 or 3 or 5% vancomycin resistant. VRSA almost doesn't exist in the world. In 20 years in the United States, we had an average of 1 every couple of years, or maybe it was an average of 1 a year. It almost doesn't exist in the world. So if you see VRSA, it's usually a mistake. It might be a mistake in the vancomycin result. It's a large, heavy molecule that does not diffuse well. So problems in disc potency, problems with media thickness can cause false resistance. On the other hand, maybe it is vancomycin resistant, but it is not Staphylococcus aureus. Sometimes when you retest these, you find that they are not VRSA, but VRE, vancomycin-resistant Enterococcus. There are a few other gram-positive organisms that do have vancomycin resistance. So that's unexpected resistance that can usually signify an error, either in the identification or in the susceptibility. You also might see unexpected susceptibility where there should be intrinsic resistance. If I see Klebsiella pneumonia, 95% ampicillin resistant, that's okay. Not every Klebsiella pneumonia has the resistance gene. So you will see Klebsiella pneumonia not 100% resistant often by zone diameter interpretation, but it's usually over 95% resistant. On the other hand, I have seen antibiograms where Klebsiella pneumonia has been 80% resistant or 60% resistant. I saw one example where the Klebsiella pneumonia were something like 30% resistant. That's not possible. In fact, that particular study did have some genome data done, and with the genomes, many of these Klebsiella pneumonias, in fact, were E. coli. So there was nothing wrong with the antibiotic result, but the identification was very incorrect. Great. Okay. And then finally, unexpected comparisons within a drug class. For example, if I have E. coli, 30% resistant to ampicillin, 50% resistant to amoxicillin clavulanic acid, that doesn't make sense. Or let me just use a different example. If I see that, well, no, that's a good enough example. If I see, for example, that 40% of E. coli, if 20% are resistant to E. coli, the susceptibility for amoxicillin clavulanic acid should be better than that. It's a better drug than ampicillin by itself. So 20% ampicillin resistant, 40% augmentin resistant does not make biological sense. Unless if you have selective testing. As an example of this, I have sometimes, so gentamicin is an older aminoglycoside, amikacin is newer. So the amikacin susceptibility is usually better than the gentamicin susceptibility on a gram-negative organism. You will often see something like gentamicin 40% resistant, but amikacin 10% resistant. That would be expected. The gentamicin resistance is higher. But sometimes you'll see it's opposite, that the amikacin resistance is higher. It is biologically plausible. It is possible for an E. coli to be amikacin resistant, but gentamicin susceptible, but it doesn't happen very often. What does happen more often is that you don't always test amikacin. You might have 1,000 E. coli without 1,000 ampicillin results, with 1,000 gentamicin results, and 100 amikacin results. In other words, they did not test amikacin on all of the isolates. They tested amikacin as a second-line reserve agent. Many laboratories will do first-line testing by disk diffusion of 6 antibiotics. And if the result is susceptible, they'll just do the first 6. But if the first 6, or some of them are resistant, they will often do a second set of drugs, the second-line panel. So in this case, amikacin is not always tested, and they only tested it on the somewhat resistant strains. So if I see 1,000 E. coli with 1,000 ampicillin, 1,000 gentamicin, but only 100 amikacin, I would not be very surprised if the amikacin resistance was higher, because they only tested it in the somewhat resistant strains. This is what we call testing bias. I'll talk about that in a few additional slides. Throughout this presentation, I will come back often to this concept about bias. I'll refer to 3 kinds of antibiograms: routine for empiric therapy, enhanced for special uses, and then an example of enhanced is multi-facility if you are in a hospital network or in a national program. This M39 document is a commercial document that one can purchase. Janet Hindler and I and other collaborators with CLSI have done some PubMed publications that you can actually access online. And this table comes from one of those free documents. And I'll show you how to find those documents later. So these are publications summarizing some of the key M39 recommendations. I'm not going to mention all of these, but just a few. So some recommendations for routine antibiograms, at least annually. You can do more if you would like, and that you might not want to publish it to your clinicians you might not want to publish your antibiogram quarterly, but you might want to run it internally if you just want an early alert that resistance is changing. So the basic recommendation is at least annually, but if you want internally, you can do more often. And if results are changing quickly, you may want to update the official published antibiogram. You should exclude things like screening MRSA nasal swabs or rectal swabs for VRE or CRE. Duplicates, I'll come back to this. Some patients, this is especially true in the human health sector. It does happen with animals, but not so often. But you often will have a human patient who might have Staphylococcus aureus in the blood and the wound and the urine, and Monday and Wednesday and Friday. You might have one person who has MRSA 20 times. I don't want to count that person 20 times, because then I will bias my statistics to the results of that person with multiple repeats. There are two problems: is that that person is going to contribute more to the statistics. More important, that person often will have more resistance. If a patient is hospitalized for 2 or 3 months, if a patient has 3 or 4 episodes, then their early episodes might be relatively susceptible, but their later episodes with that same organism might be relatively resistant. So for the specific goal of annual antibiograms, the recommendation is that duplicates should be eliminated by including only the first isolate of a species per patient in the analysis period, ignoring the specimen source and the susceptibility. Want to add on a small caveat: you can do the first isolate. What I usually do is the first isolate with antibiotic results. For example, if the patient had an E. coli that was not susceptibility tested, followed by an E. coli that was susceptibility tested, I would take the one with the susceptibility test. The one without the susceptibility test adds nothing to the antibiogram. WHONET does offer both options: first isolate or first isolate with antibiotic results. I will refer to antibiotic results as AST, antimicrobial susceptibility test. The recommendation is at least 30 isolates. 30 isolates is not a magic number. If you have 28, 29 isolates, and if the organism is Salmonella typhi, that's important information to get out to your clinicians. If it's 28, 29, Klebsiella oxytoca, it's not an organism that you need to include in your antibiogram, because you're not going to be doing empiric therapy with the suspicion a patient has Klebsiella oxytoca. On the other hand, Klebsiella pneumonia, you would want to be in your antibiogram. If you have fewer than 30, then you can include it, but give a caveat, put a footnote saying that the numbers might be too small. I'll come back again to this issue of bias. The issue is not only how many isolates. If you have 32 isolates, great, that meets this criteria. But if you have 200 isolates, that sounds like a lot, except they might be very biased. I'll talk later about the difference between accuracy and precision. I can tell you that today I am currently 26 years old, 5 months, 2 days, and 4 hours. That is highly precise and also highly inaccurate. And this will come back later when we talk about the results generated from a routine clinical laboratory. If we have a lot of data, 500, 600, 1,000 isolates, your estimates will be highly precise, but that does not make them accurate. And we'll talk about biases in a little bit. The last point is specific for CLSI. Laboratorians should report the percent susceptible, but exclude the percent intermediate and the percent susceptible dose dependent in the percent S statistic. I have another slide about a difference with UCAST. In the past, UCAST, I meant intermediate, the same as in CLSI. But in UCAST, I now means susceptible with increased exposure. But I have a slide on that. I'll talk about that in a little bit. You just saw the recommendations from the general M39 document that we first published over 20 years ago. We're now to the 5th edition, which I think is from 2022. And it goes into greater areas. Long-term care facilities, veterinary, yeast, fungal, incorporating rapid diagnostics and resistance markers, multi-facility antibiograms, antimicrobial stewardship programs. So it gives you an example of the information that has been added over the 5 editions. Biases. Many of you have seen slides like this. At the very bottom, we have the general community, healthy individuals out in the community. They're not patients, they're not sick, but they do have commensal organisms, and I'll focus on E. coli because it is so common. But you do have demographic biases. You have urban populations, you have rural populations. You have rich areas and poor areas. You have the north of the country, the south of the country. So the commensal bacteria are going to reflect the population that you drew from. Secondly, Out of these maybe 100,000 people living in the community, maybe 1,000 of them have an infection. For example, I'll just focus on urinary tract infections. You might have 1,000 women with a routine outpatient community UTI with E. coli. The majority of these women will either get better on their own over time, or they'll take an antibiotic at home and get better, or they'll go to a pharmacy, receive an antibiotic, maybe see a clinician, receive an antibiotic, and no sample was taken. So this is what we refer to as patient presentation biases. So the majority of people with non-life-threatening, simple infections will not go seek medical care at a pharmacy or a clinic or a hospital. They can just manage their disease at home. So out of the 1,000 women, maybe only 100 come to a clinic. So that's patient presentation bias. They have made the decision, which might be impacted by distance, resources, time, beliefs. So we have 1,000 infections, but we only have 100 women who come to the clinic. Out of those 100 women, we don't take a sample from everybody. The patient comes in with a routine UTI, we prescribe a drug, the patient goes home. But we don't take a sample from a lot of simple infections, because who's going to pay for it? Who pays for the sample? Also, the patients will go home. Even if we do take a sample, we don't usually have the results for 2 more days, 3 more days, and we may think that the patient is not going to come back. So this is sampling bias. Even if the patient comes to a medical establishment, many times we don't take a sample. We often will take a sample from the sickest people, or patients who tell you, doctor, I've already tried 3 antibiotics at home, they didn't work, so I decided to come today to see you to get a different antibiotic. So the samples that we do take often reflect more complicated people, perhaps people with money, perhaps people who have already failed first and second and third line samples. So we might have 1,000 women with the community simple UTI, 100 come to the clinic, maybe 20 of them, we take a sample. And then we send the sample to the laboratory. And in the laboratory, we might test ampicillin and gentamicin on all 20 E. coli, but we might test amikacin on only 5 of them as a second-line result. So these would be testing biases. In short, and let me go to the next slide. There are 2 primary consequences of bias. One is you very significantly underestimate how much disease there is. The majority of those women they didn't come to the clinic, they didn't have a sample taken, so we underestimate how much disease there is. In cases of other diseases where there's a disease control program like tuberculosis, we might be very active at trying to go out and find people who potentially have tuberculosis and do some confirmatory testing. But for non-life-threatening community infections, we generally do not do that. If we do that, it's often a special project or research program where we do want to try to elicit more representative data. So first of all, routine clinical diagnostics, we underestimate how much disease there is, but we often overestimate how much resistance there is as a proportion. The specimens are often collected in patients with treatment failures, complicated medical histories, long-term care facilities, long hospital stays. So there are no simple or inexpensive ways to avoid bias. You can do well-designed protocols with patient sampling and with patient identification, with sampling. You can try to minimize bias, and it's worthwhile to do these. But they cost money, they take time, and you cannot do a special research project on everything that you would like to do. So the reality is that we have biased data. It'd be incorrect to say we cannot use the data. You can use the data, but you need to be very careful when you do the interpretation. It gets back to this issue about precision and accuracy. If you have 5,000 E. coli, wonderful, your results will be very precise, but that does not make them accurate. They might not be very representative, and you need to keep that in mind. So part of the issue is how many isolates you test, but more important, are they somewhat representative? In a high resource country, we do a lot of sampling, so hopefully the biases are less, but they're still there. In a low resource country or a low resource setting, often we only get samples from the most difficult patients, so the results can be highly biased. So the numbers are small and the numbers are biased. So what can we do? It is crucial to keep the issue of bias in mind whenever we review results, and we must proceed cautiously when making conclusions and recommendations. For certain surveillance objectives, the impact of biases is devastating, but for other uses, the bias is not so important. High impact. If you are trying to do disease burden estimates, routine clinical data cannot give you you cannot have a lot of confidence because the majority of patients do not get sampled. Treatment guidelines. We can describe very, very well the bacteria that arrive in the laboratory, but those do not represent the general community that we want to make treatment guidelines for. So the biased data can have a very significant impact, and this is the subject of antibiograms. So there's a high impact on our primary objective for today. There are other examples where the biases don't have a high impact, it's medium impact. Advocacy and awareness. We have some general statements. Resistance is bad. It's getting worse. It's diverse. The numbers don't have to be completely accurate for this purpose. For a lot of surveillance programs, yes, we see that this country, the percent resistance is 20%, and then it was 25%, and then it was 30%. Is 20% accurate? It might not be accurate, but we can still follow the trends. And we can say that some countries it's more, some countries it's less. Some facilities it's more, some facilities it's less. So for this purpose of advocacy and awareness, the bias doesn't impact the general decision. The general decision is we need to fund these projects. This is an important issue. We need to address the issue about emerging resistance. If the numbers are completely accurate, is less important, especially since many times we present national statistics. For example, we might say that in China, 30% of the E. coli are resistant, but that's an average the national program had over 3,000 or over 1,000 labs. It's just an average. So the national average is still valuable for global comparisons, but individual clinicians, they don't want the national average. They want the number for their own province or their own facility. And then lower impact, outbreak detection. If you have biased data, you should still be able to find outbreaks. Normally you have like 5 salmonella every month, and then you have 30. Yes, the increase might be because of biases, but it's more likely because of an outbreak in the community or the hospital setting. Trend monitoring, resistance seems to be stable, or it seems to be getting worse. Recognition and confirmation of new resistance. Does my facility, does my country have CRE? Does it have VRSA? Does it have VRE? So it doesn't matter if there are biases. This is a yes or no question. If you find one isolate, yes, you can confirm and investigate whether it was a laboratory error or it was true. Along the same lines, continuous quality improvement. If you have a VRSA, it's usually going to be due to a mistake in the identification or in the susceptibility. If you do good quality susceptibility testing, there are not that many variables. There's the dish diffusion, there's the dish, there's the medium, there's the inoculum. But with organism identification, there are many additional variables. It requires the knowledge of a trained microbiologist with flowcharts. It requires oxidase and catalase and all of these other tests. So in a place that does relatively good susceptibility testing, strange results are often due to a mistake in the identification. Another thing about biases. So where do we want to get representative data? And I want to say that it's more complicated than you think. People say, well, I would like to know patients with pathogens. I want to know the results from those 1,000 women out in the community. But how am I going to design a study? Am I going to knock on doors and ask women, do you have symptoms of a UTI? And there are projects that do that. So it is possible to do community surveys of women in household surveys. But it's very expensive. You have to have outreach to go out to the community. That could give you good estimates for resistance out in the general community. Well, but maybe I only look at the women coming to my clinic, and people might criticize that and say, you can't look at only the women in the clinic because it's going to be biased. Those women don't represent the 1,000 women. They represent the 100 women coming to the clinic, and that is true. From these women, I cannot get a general estimate of resistance in the community, but I can get a good estimate if I do a random sample of these women, of women coming to my clinic. And that itself is important. As a clinician seeing patients in my clinic, I'm not responsible for treating the women at home who didn't come to see me. I am responsible for the women coming to my clinic. So yes, there's a bias. These don't represent the general community, but they do represent the women coming to my clinic. And those people, I need to make a decision. So from one hand, it is biased with respect to the community, but it is not biased with respect to the people I am immediately responsible for. Similarly, ICU patients, you might say, well, you can't use those isolates, they're all from the ICU. I say, yes, but I'm in charge of the people in the ICU. So the word bias is relative to the objective. Do I want an antibiogram for treatment recommendations to the general community, or to the women coming to the clinic, or to the ICU patients? So bias is with regards to how do you plan to utilize the data. I used to teach biostatistics, and I would generally say the data are not biased. The data are what they are. The data represents something very well. The bias comes with the extrapolation and use of the data. So if I have data from only ICU patients, that's what they are. They're not biased. That's what they are. They're ICU results. But if I try to extrapolate that to make a community treatment guideline, the bias is coming in with regard to the use. I've extrapolated to a population that they really don't match. What are the impact of bias on the results? We underestimate disease. We already talked about this. Okay. So what is the danger with antibiograms? The focus of today's call. Many patients with simple community infections have no diagnostic samples processed by the laboratory. The samples that we do receive often represent patients with treatment failures, complicated medical histories, long-term hospitalization, or living in a long-term nursing home. This is true in all countries, but especially in low and middle income countries. So the observed %S that you see in the data might be very precise, but not very accurate. So if we say that 95, well, there's an example there. For example, the laboratory might see that 70% of the E. coli are susceptible to ciprofloxacin, and that might be 5,000 isolates. That number is highly precise, but that might not represent the general community if we could go out to do a community survey, or if we surveyed everybody, if we sampled everybody coming to the clinic. You may have a representative sample, which might show that the susceptibility rate is 90%. So if I base my clinical decision on the 70%, well, that's on the next slide. As a result, clinicians might incorrectly decide with 70% susceptibility, this is not good enough. I will instead use imipenem. So the threat of, I'm a big fan of surveillance of resistance. I'm a big fan of utilizing these data to support important objectives, but there is a risk. If the observed susceptibility is too low, you might not consider it for treatment, and you might jump quickly to a reserve agent. So there are two problems. Is one, if you've lost the benefit of a lower cost drug, and worse, you're starting to use imipenem and vancomycin and these expensive or reserve agents we want to preserve for the future too early. Because of the risk of inappropriate therapy decisions, because of the biases by non-experts, some surveillance coordinators have decided I don't want to present the percent resistant. I don't want to present the percent susceptible. I want to present the percent resistant. They choose to emphasize the value of antibiograms for monitoring emerging resistance. They want to de-emphasize the use of antibiograms by non-experts, by clinicians, community clinicians, hospital clinicians. They don't emphasize the percent susceptible. They don't emphasize using the antibiogram for treatment decisions by non-experts, because they're concerned that people are going to stop using first-line agents that work well to switch to reserve agents. The internal laboratory committee, the Drugs and Therapeutics Committee, Standard Treatments Guidelines, of course, they're going to see the real numbers. They can look at R and I and S. But antibiograms, they might want to use it as a surveillance tool. And for treatment guidelines, they're just too worried. So that's something to consider. Now, this difference between CLSI and UCAST. For CLSI and in the past UCAST, I meant intermediate. In fact, when I started with this many, many years ago, there was another category called MS, moderately susceptible. And I, at that time, meant indeterminate. And then they combined I with MS to create the intermediate. The intermediate either meant the bacteria was somewhat resistant or it was just unclear. So the bacteria might have, so with CLSI, I currently means intermediate. The bacteria may have decreased susceptibility to the antibiotic, and the clinical value of the antibiotic is uncertain. And whenever a clinician sees I with CLSI, we tend not to use it for treatment decisions, for treatment choices, unless if we have no other options. So it does make sense to present antibiograms using the percent susceptible. And then, not a large number, I don't recall now, maybe 5-6 years ago, UCAST said, well, I means susceptible with increased exposure. In other words, from a clinical perspective, the patient should respond to treatment. They're saying the bacteria has somewhat decreased susceptibility to the drug, but with higher doses, there should be a successful clinical outcome. CLSI has a similar concept called SDD, and I should put that on the slide. SDD for CLSI means susceptible, dose-dependent. The same thing, it's a little bit resistant, but higher doses, the patient should respond to therapy. So the CLSI SDD is very similar to the UCAST I. So for the antibiogram, maybe, and this is different people are doing it different ways, maybe you should present the percent S, truly susceptible, and I separately, just have 2 columns. Or do the percent S plus the percent I. At the present time, we call this in WHONET non-resistant, which is accurate, but it's also confusing. My antibiogram is not percent susceptible, it's percent non-resistant. That is correct, but we might try to come up with a different terminology. What we'd like to call it is susceptible-ish. That's not a real word, but susceptible-ish means it's either truly susceptible or it is susceptible with higher exposure. My impression, but I would appreciate guidance from especially Europeans utilizing UCAST, I would think that most people probably present percent S and percent I. Or you can present percent S and percent S plus I separately so that you can see the difference between truly susceptible and somewhat susceptible. So key elements of a good antibiogram. This slide comes from Jens Thompson. Basic facility, and this comes out of the M39 document. You should have a name, a time period, the antibiotics. WHONET does not yet group antibiotics by class. We plan to introduce that. We just use the sequence that the person has created. But it is convenient to put the aminoglycosides together, the susceptibility, quinolones, others, number of isolates. And here we have gram-positive and gram-negative. In this slide, they've been integrated into one. However, it is more traditional to have one page for the gram-negative antibiogram and a different page and a different table for the gram-positive antibiogram. And here you can see MRSA and MSSA separately. This is an example of an enhanced biogram feature. It's beyond the simple. Whenever you go beyond the simple normal recommendations, we call that enhanced. Here, for example, is Salmonella typhi, blood isolates only. Many times we'll do this with nitrofurantoin, selective testing. We did not test nitrofurantoin, especially by disk diffusion. On all of the E. coli, we only tested it when it was a urine isolate. Of course, if you're doing MIC testing with a panel, you usually test the same drugs always. And then footnotes at the bottom to help educate people about caveats and special rules. Some people like to use colors to assist in treatment decisions. Let me just check my time. Good, we're doing well on time. And in this particular slide, green is good susceptibility. And I'm saying good in quotation marks. It's good by this threshold, and I'll come back to why sometimes that can be a problem. So in this particular slide, green is more than 80% susceptible. Yellow, 70 to 79% susceptible. Red, less than 70% susceptible. So this is nice because it gives a visual impression of where there is a lot of resistance or not a lot of resistance. I like it from that perspective. It highlights the set of good and, again, the word good and bad is difficult, high and low resistance. But the use of colors can be problematic for two main reasons: the biases. For example, the observed percent susceptible might be 70%, but that's in a biased sample. If you had an unbiased sample, it might be 85% susceptible. So the problem is that it got a yellow color because we're using observed estimates from the laboratory, but the broader community, it might actually be green. So one trouble with this is, with a quick look at this, I would say, oh, if it's in green, this is a good drug and I can use it to treat my patient. And if it's yellow, I don't want to use that. So the problem with colors here is that it's encouraging people potentially to make bad decisions. So the resistance estimates derived from routine sample often do not reflect the general community or the general clinic that they represent. So the colors are increasing the risk that you might make an inappropriate choice because you're ignoring the biases. And we don't, even if you're not ignoring it, we don't know what the true susceptibility rates are. That's one problem. And what should the threshold be? Here, somebody decided the threshold should be 70 and 80%. But it doesn't consider things like severity of disease. For things like meningitis, which is immediately life-threatening, or things like gonorrhea, which is not immediately life-threatening for most people, but it's from a public health perspective, a successful outcome is very important. In these situations where there's either life or death on the line, or there's a significant public health risk of transmissibility, a lot of guidelines will say 95% susceptible. And if you have susceptibility less than 95% where there's meningitis, you might want to do two things. You might want to do a more random survey to try to get a more accurate answer. Or you might want to switch to a different first-line agent. So susceptibility is less than 95% in a life and death situation. And if this is an unbiased sample, then you might want to switch to a different first-line agent. In vivo, in vitro correlation. I have it backwards. It should be in vitro, in vivo. In vitro is what the laboratory is telling you. So as one example, Salmonella enteritidis will often be 90% susceptible to gentamicin. That sounds great. That's the in vitro, of course, meaning glass. So the laboratory result might be 95% susceptible Salmonella with gentamicin. However, clinically, it really doesn't work. It's an intracellular organism. You don't have great penetration. So it's high susceptibility, but low clinical efficacy. That's one example. Another example with a non-life-threatening infection, there was a study done in the United States that if we look at cost effectiveness in their particular patient population, they felt that cotrimoxazole was a reasonable first-line therapy choice if resistance rates were lower than 23%. 23% says, aren't there going to be a lot of treatment failures, like 23%? And you have to keep in mind, a lot of the patients with a UTI are going to get better eventually anyway. There's time to come back. You tell the patient, if you don't start getting better in 2 or 3 days, please come back and I'll change the antibiotic. So from a cost perspective, we're not worried about immediate mortality. We do have time to change the antibiotic. And in their view, from a cost perspective, 23% resistance for them was a reasonable threshold. So the question is, what should the threshold be for these colors? 90%, 95%, 80%? It depends on the bias, depends on the severity of disease. It depends on what your objective is, a successful first-time therapy or successful first or second or third-line therapy when we know that the patient can come back. There's a different use of colors. And the use of these colors look at trends, and this example came from Hawaii that Jens found. And in this one, if you look at the legend at the bottom, they compared the 2016 data with the 2015 data. So green meant the antibiotic is more effective now than it was. Susceptibility is getting better with dark green. And then light green, susceptibility is getting a little bit better, 5 to 9%. Yellow, 5 to 9% decrease, susceptibility is getting worse. 10% red means the susceptibility is worse than 10%. And then just a simple wider gray, that means susceptibility is within the 5% range. It's gone up within 5% or down within 5%. What I like about this is it shows you very clearly how this year compares to the previous year. Green is good, susceptibility is getting better. Red is bad, it's getting worse. So this is a different use of colors. These have been examples primarily of routine antibiograms. Here are some examples of enhanced. I already mentioned MRSA, MSSA. Here you see a routine antibiogram with bloodstream infections by species. And here you see they're all averaged together, all gram-negative rods. And what's interesting about this is that you might have a patient with potential sepsis in your emergency room, and it's going to take 2 days to get the antibiotic results. But if there is a positive early gram stain from a urine, from a blood, then I know it's a gram-negative rod, so it can be helpful to group the gram-negative rods together so I can make my empiric therapy choices while I wait for the specific species. I'm going to show 2 examples of multi-facility antibiograms. These data are from Los Angeles County. And you see, for example, Acinetobacter, there were 2,700 Acinetobacter from 75 different hospitals. Citrobacter from 45 hospitals, and you can see the susceptibilities. You also see the letter R when there is either intrinsic resistance or it's just, for example, Staphylococcus aureus is not intrinsically resistant to penicillin. It is usually resistant, but it's acquired resistance. So the R here either means intrinsic resistance or very high, acquired resistance. So here for the multi-facility antibiogram, the facilities have all been averaged together. This example is from Massachusetts, and they show the range. So in the middle, in this example, what drug is this? Cefotaxime. The average is 44% susceptible for Acinetobacter with, what drug is this? Acinetobacter. With cefotaxime, right. And you see the range from this. So this is an example of, it's a partial box plot. The minimum value, the maximum value. You can also put in the percentiles, the quartiles to get a true box plot. Oops. So this tells you 2 things. It tells you what the average is for the state of Massachusetts, but it also tells you the range. For example, I'm at a university hospital, and I would expect to be higher than the average. So here you see in the blue X, that's the result for this particular hospital. So I can see how my hospital compares to the average. A community hospital, a children's hospital would often be less. A university hospital, city hospital would often be higher. Jens found these wonderful videos. What is an antibiogram? 2 minutes. Interpreting the antibiogram. Selection of antibiogram for successful antibiotic policy. One more, how to read and interpret an antibiogram. And these resources will be available to you online. There are several publications. Here are 2, the antibiogram key considerations. This one I was involved with from Ghana. Those are examples from the human health sector. There are some nice One Health examples integrating human, food, and animal and environmental results. There's a publication quoted down below which did a survey, and they found that there are not a large number of national integrated One Health systems. Almost all, no, in fact, all of them were in high resource countries, mostly Europe, US and Canada, and Japan. Group 2, there's a little bit of a diversion. It's not about antibiograms, but group 2 is integrated operations where the human, animal, food sectors are collaborating extremely closely with the same panels, with the same database, with the same publications. Everything comes together in an integrated way. I'm getting sun in my eye. I'm just trying to move around a little bit. I'm going to move over here. Okay. Or let's see, that's my call. Okay. So group two, everything, that project is very integrated between the sectors. More common is group one, where it's done in parallel. The human group to the human isolates, animals to animal isolates, food to food isolates, and it's different databases, but they do coordinate publications, reports, messaging. So each group is sort of working separately, but they integrate the messages. Group three, everything is collected on the human side. So from a data management report, it's led by the humans, but with feedback from the food and animal sectors, environmental. And then at the bottom, this does not include human isolates. This is led by the food groups. So these particular examples do have websites, so if you're interested, and they mostly present antibiograms on animal health data. So they have click on human, click on animal. These are nice examples. So the top four also integrate sectors, but they also integrate with antibiotic use data. The ones at the bottom do not integrate with antibiotic use. Useful links. Let me get my phone. Let me just check the time. Good. So we're almost finished the PowerPoint. So I want to show a few websites. I'm just going to say CLSI M39. So if you are not a CLSI member, this is $180. If you join CLSI, then these documents become much cheaper. And if you're going to buy many documents, it makes sense to become a member and just compare the prices. And it tells you about it and read sample. And you can see Janet Hindler is the first author, and I'm one of the authors later down. And yes, from January 2022. And an abstract of what the document is about. I'm going to go back and search for CLSI VET05. This is generation presentation of AST data from bacteria of animal origin. I'm showing CLSI because UCAST has not made these kinds of documents. So even though people might use UCAST, there's not a UCAST document with these same kinds of recommendations. So people still often use the CLSI versions. I'm going to go to CLSI free. I'm doing a search at the top, CLSI free. I've been showing this for over 10 years, but they recently significantly reorganized it. So I'm going to show that. Resources, CLSI. And where is it? It took me a while to find it. It's down here, CLSI micro free. So that's one change, is the landing page is changed. So if I click on CLSI micro free and I click on this arrow, I do have to log in. The login was not necessary in the past, but I put an email. And I click on login. One of the things they did is they have integrated the human and the animal documents. There used to be separate links, but now they're together. So these documents are available for free. The M100, routine human bacteriology. M45, rare and fastidious human bacteriology. M27, mycology, especially yeast, like Candida. M23 is not needed by most of you. The M23 is more guidelines. How do you make breakpoints? How do you make QC ranges? It's the methods documents for people who are involved in developing interpretation guidelines and test methods. The VET document, unfortunately, it's just the one document, the VET01. If there are any CLSI members, I hope that somebody might consider. There's also the VET06 and the VET0304. CLSI VET06 is for rare and fastidious organisms. It is similar to the human M45 document. And then the CLSI VET03, VET04, NIH PubMed. Oh, no, I didn't mean to do NIH, just PubMed. So my name is not a common name. So if I put Stelling, M39, yeah, that's what I was showing. You can see these two publications, so it's easy to find these published recommendations. Okay, good. So I'm going to stop sharing. No, I'm going to close PubMed, go back to my PowerPoint. I'll talk a few comments about the new breakpoint tables because it is relevant for today. For many, when I started a long time ago, CLSI and the French and the Germans and the Swedish all had different guidelines, and there was one very, very long table for all organisms. And then there were a few exceptions for like Streptococcus pneumonia, Pseudomonas. So there was there were what we called general breakpoints that was applied to all bacteria with some exceptions. And that's how we implemented WHONET. Of course, over time, around the year 2000, they started to separate Enterobacterales, Staph, Enterococcus. So then there were species-specific tables. And for the last about the last 7 years, we've had, or maybe 5 years, we've had both the general approach and then the specific approach. And now we've offered the new approach for several years now as an option. But we hadn't incorporated at that time the intrinsic tables, and the intrinsic resistance tables are very important. The bottom line is we've had these new tables available for many years, and many of you do use the new tables, but we are now changing the new way to be the default. So the difference is not that we're putting something new in, but that we're changing the new way to be the default. The CLSI tables were getting more and more complicated, especially for things like the veterinary breakpoints, where there would be E. coli breakpoints for, I think for horses, but dogs did not have an E. coli breakpoint, that had an Enterobacterales breakpoint. And with our old tables, it was getting too complicated to manage those. So for full compliance with CLSI and UCAS, we have made these new tables. That's one advantage. We've also integrated these things that epidemiological cutoff values. Most people around the world call them ECOFs. CLSI, it's called ECV. It means the same thing. The idea of, well, this is a different point I want to make. Many people incorrectly think that the purpose of UCAS and CLSI is to find resistance. And by that, I mean resistance genes. There's a misunderstanding when CLSI says S and when UCAS says S, what they are viewing is a clinical perspective. If you have an E. coli that it says is susceptible, they're not saying there is no resistance gene. They're saying that there is a high chance of clinical success. So it's what we call clinical susceptibility. So the purpose of CLSI and UCAS is not to find resistance genes, is to predict the clinical outcome. So there are bacteria that are clinically susceptible and the patient should get better, but are still a little bit resistant. Then the epidemiological cutoffs has that other objective to find resistance genes from a phenotypic perspective. It used to be known 30 years ago as microbiological resistance or susceptibility. So clinically susceptible means that the patient should get better, even if there's a resistance gene. ECOF wild type is the expression we use. Wild type means there's no evidence of a resistance gene from a zone diameter MIC perspective. So with our new tables, we can support the ECOFs. We've integrated intrinsic resistance tables. So previously, if you put Klebsiella pneumonia with ampicillin, it would look at the zone diameter and it would interpret the results. So most Klebsiellas are resistant, 6 millimeters, 8 millimeters, 10 millimeters, and WHONET would say resistant. But sometimes you would have Klebsiella pneumonia and the zone diameter would be 30 millimeters, which is a susceptible value. So by using the zone diameters, it would be called susceptible. And it might be a Klebsiella that has lost its resistance gene. Even with repeat testing, it is clearly susceptible. However, with the intrinsic resistance rules, if it's Klebsiella pneumonia, if it's ampicillin, we're just going to call it R. We're just going to change whatever, it doesn't matter what the measurement is, we're going to call it R. And this is helpful to protect against mistakes in the susceptibility test result. Or there's not always a mistake in the susceptibility test result, but we have to remember that the laboratory test is done overnight, 18 hours. But the patient might be on the drug for several days. So there are examples where on day 1, the bacteria will be susceptible. But if you continue to treat the patient for 10 days, there's a high risk of a mutation, a high risk of resistance from that organism. So the intrinsic resistance rules says if it's Klebsiella pneumonia, if it's ampicillin, it's resistant. Ignore the zone diameter. And we have put those into WHONET. You can turn them off. One thing I don't like about the intrinsic resistance rules is you can hide accidentally mistakes. If a lot of your Klebsiella pneumonia are really E. coli, we're going to change the ampicillin to R, even though they are not R, they are not S, and the mistake is not in the susceptibility, the mistake is in the identification. I'll talk a little bit more about that, because you can turn it on and off. Dynamic breakpoint selection. Today, I want to analyze my data with the 2020 breakpoints, or the 2025 breakpoints, or the 2016 breakpoints. That was not possible with our old tables. With the new tables, you can dynamically change the years. Having said that, we don't recommend generally you change the years. If you are analyzing data from 2010 today, you should not use the 2010 breakpoints. You should use the 2025 breakpoints. That is a CLSI M39 recommendation. Why are we using new breakpoints to reanalyze the old data? The reason is that the method hasn't changed. It's still the same test we did in 2010 that we do today, but our understanding of clinical susceptibility and resistance has improved. So even with the old data, the recommendation is to use the new breakpoints. We still sometimes want to use the old breakpoints so we can do that comparison. It used to be called susceptible. It is now called resistant. A very good example of this is with imipenem and meropenem back in 2010. CLSI was calling a lot of these susceptible. UCAS said, we don't think they're susceptible. UCAS was right. CLSI changed the breakpoints so that some of these were now resistant. So even for the old data, you should generally use today's breakpoint. The new breakpoints are also more configurable. For example, for many years for Streptococcus pneumonia, for good reasons, WHONET used the meningitis breakpoints as the default. There was better agreement, it was high-level resistance. But for other good reasons, the current recommendation, at least from EARSnet, is to use the non-meningitis breakpoints. So now you can control which breakpoints are the default. If you were doing the detailed RIS analysis, or if you were doing clinical reports, WHONET shows you all the breakpoints. On the other hand, if you're just doing a summary, WHONET just chooses the quote unquote the main breakpoint, the default breakpoint, so you can configure which one should be the priority one. A very important element is the new WHONET tables can be used with WHONET, of course, but the WHONET tables can also be utilized by other groups, and so there are a small but increasing number of groups, Doctors Without Borders, MSF, Vietnam, and a few other groups that do utilize the WHONET tables for their own internal purposes. If you have an interest in that, we can provide information. The tables are available within WHONET. They're also available on GitHub. Points to look out for. I want to move on to WHONET, so I don't want to spend much time on this. As I said, according to the old tables, who might tell you that 95% are ampicillin resistant. With the new tables, it's going to say 100% because it's automatic. The problem with the automatic application of intrinsic resistance is you can hide mistakes with identification. So if you're doing the hospital antibiogram to give to clinicians, I would like to apply the intrinsic resistance rules. But if I want to do an internal quality check, I might want to turn off the intrinsic resistance rules just to make sure that there are not mistakes. The Klebsiella should be over 95% resistant, and other examples of intrinsic resistance. Intrinsic resistance is often not 100%, but it's close to 100%. You'll see more examples of a question mark. In WHONET, R means resistant. S means susceptible. In WHONET, I always says intermediate. We do need to change that. We're in the process of changing it. For UCAST, I should mean susceptible with increased exposure. We haven't implemented that yet. But there's another category, question mark. For example, Pseudomonas aeruginosa and nitrofurantoin. Maybe there's UCAST, I don't know, but with CLSI, there are no nitrofuran breakpoints for Pseudomonas. So for the old tables, WHONET would use the breakpoints and the zone diameters for an E. coli. With the new tables, you get a question mark because there is no breakpoint. Same thing for like vancomycin disc. WHONET will put a question mark there for Staph aureus. It is not a valid test. There are no general breakpoints. You should not be doing the test. It doesn't matter what the zone or the MIC is. WHONET, CLSI, UCAST does not have a breakpoint. So you might see more question marks. Finally, moving on to WHONET and how do I do actually I did want to show that slide. And almost there. Okay. So right now I will go through 4 things. How do I do an antibiogram manually? I'm in charge. I want these organisms. I want these filters. I want this one per patient. I'm in control. I can show you how to, once you've done that, you can make a macro so that you can repeat the test a month later, a quarter later, a year later. Macros are extremely valuable for repeating things over time. First, you learn how to do it manually, and then you save it as a macro. We'll then show you the WHONET standard reports, and we have reorganized this area. So many of you will have not seen this yet, as well as user-defined reports where you create your own reports. Here, this is a summary of what I'm about to show you, but I'll just show you on the screen. Demonstration, that's what I will do now. How do you make a macro? It's in the slide presentation, but I'll show it to you live instead. And the demonstration of the macros, WHONET standard reports in Word and or Excel, user-defined reports. So now let me get to the live presentation. So what I'm showing you is live on the WHONET website. And I do want to, this is, you see here it says lab.who.txt. Let me copy and paste that. C drive, WHONET, paste. Replace, yes. So I'm opening WHONET. And I'm going to open the laboratory just in the normal way. And WHONET says, for many years, it's basically a summary of what I was just saying. For many years, WHONET has used a mixture of external tables and internal logic for AST results. For the past years, we have also offered a more modern approach, the new way, but you had to select this feature. We are now changing the recommended strategy to the new ways, which offer several examples that I already mentioned. Your laboratory configuration is currently set to the old breakpoints. Would you like to go to the new breakpoints? And there's a link here which provides some of those comments that I just made. And I can say, yes, I want to go to the new breakpoints. No, I don't want to go to the new breakpoints, but I can go to the new breakpoints later. So you don't have to decide immediately. Or ask me in 1 month, because if you're not in charge, you want to learn more about it, you might not be ready to say yes or no. And you can say, just ask me next month. And you can go back and forth. You can say yes, and you can say, I want to go back. So WHONET is now going to ask you, do you want to switch to the new way? Yes, I do. And then the next time, when I open, it's not going to ask again. It just asks that one time if I say yes, or if I say no. And if I say ask me in a month, it'll just ask you next month. And that gives you more time to learn about it. Okay, good. Good. Okay, so I am now in WHONET. I'm going to click here where it says data analysis. 2 options, interactive data analysis where I am in charge. Quick analysis where it's been predefined. Predefined by us in Boston or predefined by you using macros and reports. So I'm going to start with the interactive analyses. Adam, I did switch from the PowerPoint to the demonstration. I did forget to ask, are there any comments or questions in the chat box?
None so far, actually. So if anyone has any questions or comments, please type those in and we'll try to get to them at the end of the session. Thank you.
Thank you. Great. So hopefully all of you, most of you, are very familiar with the screen, which has not changed. I want to go to analysis type. I want the %RIS option, but not the detailed report. The detailed report will tell you R and I and S and question mark and the breakpoints and the zone diameter histograms and the MIC histograms. That's number 1, the detailed report. I'll do number 2, the summary report, which is really the antibiogram report. It's the same information, but less information. So here, the first change you're going to see on the right is before you had the choice, you could choose S or I or R, but now you can do more than one. There's a change here in Windows. Unfortunately, it looks like you have 3 options here. You don't have 3 options. If I move over here, this is not a WHONET change. This is an unfortunate Windows change. I don't like the new Windows version of this. As I said, it looks like there are three options. There are not three options, but if I go over to the right, I can now see the drop-down box. So I can see SIR, non-resistant, non-susceptible, intermediate, susceptible, dose-independent, wild type, non-wild type, that's for the ECOFs. So you only see the three options, but it is about, I don't know, 10 options or so. So I could do the percent S and the percent R and whatever. So I would generally recommend that if you use CLSI, you should choose percent susceptible. I would generally recommend, and I would appreciate feedback on this, if you're doing UCAST, what you probably want is percent S plus percent I. STD is CLSI, so it's not relevant for you. So as I said, the UCAST I is basically the same as the CLSI STD. That's why we have them grouped together. Okay. So for CLSI, people traditionally follow susceptible. UCAST, you can do purely susceptible, or you can combine the S's and the I's to get your clinically oriented treatment statistics. So one change, this is now a checkbox. Before you could only choose one. I'll just choose one because it's easier. Most people will only choose one, but we did want to offer that flexibility. That's one change. There's another change we did introduce maybe 2 months ago where, well, I'll talk about that later, but you can say 30 isolates, 40 isolates. I'm going to come back to that. I'm going to do a simple antibiogram, percent susceptible. I can choose the antibiotics that I want for my antibiogram. I'll come back to those options later. I just want susceptible, percent susceptible. Okay. Organisms. Let me go to organism groups. And let me choose all gram-negative organisms. I don't have to put all. I can say E. coli, Klebsiella, Serratia. So if you have a specific list in mind for your antibiograms, just put that list in. Maybe there's some gram-positives, some gram-negatives you want, and some of them you don't want. So I chose all gram-negatives, and then I can filter out later, and I can delete later in Excel things I don't want. So I want all my gram-negative organisms, or I can do all Antibacteriales, and then I can do the non-fermenters separately. I won't do that now. I'll just do all gram-negative organisms. And data files. This is my one month of human health data. If there's time, I would like to show One Health data, and you can do stratifications. I can do all isolates averaged together, but I can also separate it: human, animal, food, cat, dog, fish. I hope there's time for that. But I'll just start off with the human antibiogram with the human health data. The first file here, January 2020, is 1 month of human health data from a small community hospital. The second file has 400 isolates, 100 human, 100 animal, 100 food, 100 environmental. So I'm going to choose the 1 month of human health data. Okay, and begin analysis. So here I see all of my gram-negative organisms, and you can see, for example, at Chromobacter, there was only one isolate. So of course, with one isolate, it's either going to be 0% sensitive or 100% sensitive. Here we have 3 isolates. It's either 0%, 100%, or here it's 2/3%. So these numbers are tiny. I can click on number of isolates once. I can click on number of isolates again. So the 3 most common organisms, or the 4 most common organisms: E. coli, Pseudomonas, Haemophilus, Klebsiella pneumonia. Klebsiella pneumonia, there are only 23 isolates, but keep in mind, this is only 1 month of data. If I had 12 months of data, these numbers obviously would be much larger. I can look at my graph. Here's my graph for E. coli, which is a relatively susceptible organism. My graph for Klebsiella pneumonia, also relatively susceptible, except for the ampicillin and a few other drugs. I can look at the antibiotics, the organisms for ampicillin. A few organisms like E. coli, Haemophilus influenza, Proteus mirabilis, and Proteus species do not have intrinsic resistance, and they have a lot of susceptibility. On the other hand, ABA, Acinetobacter, ECL, Enterobacter cloacae, KPN, these have intrinsic resistance. So resistance is either complete or it's partial. It's very high resistant, very low susceptibility. So one problem with this is that some of these numbers are too small, 9, 8. So yes, I can export it to Excel, and I can manually delete them in Excel. Here, for example, let me go to E. coli. There were 86 E. coli, but I'm going to move to the right. And you see these columns called number. There were 86 E. coli, and they tested ampicillin 85 times, aztreonam 85 times, cefotaxime 85 times, nitrofurantoin 57 times. It's a urine drug. They did not always test it. AMC, amoxicillin clavulanic acid, 57 times. They have decided to test it in urine, but not other things. Amikacin 8 times. So what you're seeing here is there are certain drugs they always test as first-line agents. There are other drugs that they only test in urine. There are other drugs that they only test as second-line therapy. And these different things are introducing different kinds of bias. Nitrofurantoin, it doesn't bother me. I'm not getting overall statistics for all nitrofurantoin, but I'm getting nitrofurantoin statistics for urine, which is fine. That's what the drug is intended for. So I'm not worried about that kind of bias because it is appropriate for this organism. On the other hand, they only have amikacin results 8 times. And out of the 86 E. coli, they only tested amikacin probably on the multi-resistant strains. So even though, and this is only 1 month of data, if this were 12 months of data, this would be about 100 amikacins. But 100, even though the number is over 30, it's still not representative. I might have 1,000 E. colis with 1,000 ampicillins and 100 amikacins. And it's not representative. Yes, it's larger than 100, but it's only 10% of the isolates. So these denominators here, the denominators here on the right, the data analyst should look at those. The clinician doesn't. The clinician doesn't care about those things. The clinician cares about these numbers on the left. Okay, good. I'm going to click on continue and show you some of these features here. So here, this feature we introduced about 2 months ago. Please only show me if there are 20 isolates or more. Please only show me if it's at least 20% of the bacteria available. This used to be fixed inside the software. I'm happy with the 20, this 20, the second 20. We might change it to 50. I haven't decided, but now that you can configure it, you can decide what you want. So here we want at least 20 isolates. Why did we choose 20 instead of 30? The official recommendation is 30. We put 20 just to show you a bit more. As I said, if you have 29 Salmonella typhi, that's important information. It didn't reach that magic number of 30, but it's still important information. So by showing you 30, we're showing you more. And then if you don't want to tell the clinician, just delete the row. So we put the threshold a little bit less so that you can have a decision. You know, if you have 25 Salmonella typhi, I want the doctor to see that, and I can put a footnote. If I have 25 Klebsiella ozonii, I really don't care. I'll just go ahead and delete it. We're not making empiric therapy decisions for an infrequent organism. Okay. And the 20, I think that 50 might be better, but we haven't changed the default, but you can change it however you would like. So what happens if I turn on those two features? When I click on begin analysis, good, okay. When I turn on that, you see that the majority of the bacteria disappeared. You need at least 20 isolates. So it has cleaned things up a lot. Also, you can see amikacin, it used to say 8 isolates. It doesn't say that any longer. They've automatically been deleted. Not only has the denominator been deleted, but the statistic has also been deleted. There used to be a number here. So we have deleted organisms that have fewer than 20 isolates. We've also deleted antibiotics that were tested fewer than 20 times or fewer than 20% of the time. So this antibiogram is a lot cleaner. Great. That's 86 isolates, but how many patients is that? I don't know. Is it 86 different people? Is it one person 86 times? So this is not yet the official antibiogram. I'm going to click on continue. And I'm going to go to 1 per patient. By default, WHONET included all of the isolates. But I don't want all the isolates. I just want to do it by patient. There are many options. I mentioned first isolate only, which is, and I mentioned the second one, first isolate with antibiotic results. So I'm going to choose that second choice. There are some other options: average result, most resistant, most susceptible, one result per interpretation, and these also have value. First of all, it makes a difference. It doesn't make a big difference usually. Like if you do by isolate and by patient, that can make a big difference. Sometimes you'll have people that have E. coli 20 times. And if you don't get rid of the repeats, you can significantly impact your estimate of susceptibility, your estimate of resistance. And I've seen the numbers change by over 10 or 15%. With the repeats, it might be 40% resistant. Without the repeats, it might be 25% resistant. So the difference between by isolate and by patient can be a big difference, especially in a large university hospital in a high resource setting, because we do a lot of repeat testing. In low resource settings, in community settings, it's less of an issue because people don't have a lot of repeats. There are repeats, but just not so many. The majority of patients have E. coli once, or they have Staph aureus once. It's uncommon to have a repeat in the same calendar year. So you still want to get rid of the repeats. In a university hospital, this is very important. For community data, it is important, but it's less important just because there are not as many repeats. But you still want to do it the right way. This removing repeats does require a somewhat reliable patient identifier. And unfortunately, a lot of places do not have patient identifiers. The patient's number is like 1, 2, 3, 4, 5. If I see patient 1, 2, 3, 4, 5, I know it's the same person. A lot of times people don't have numbers, unfortunately. So then WHONET will use the name, John Stelling. And that's obviously better than nothing, but you might have different people with the name John Stelling. Having said that, it's still pretty good, though. There are not a lot of people with the name John Stelling with the same bacteria, like E. coli, in the same calendar year. So if you don't have numbers and you have names, it's still pretty good. It won't successfully remove all the repeats because sometimes different people, like Tom O'Brien, many people have the same name. But it's rare to have the same name and the same organism in the same calendar year. But the best thing, of course, is to have a reliable patient identifier. This other option is really not for the pharmacy. It's more for infection control. In the course of the year, I have one question: how many patients had bacteremia? My focus is on the patients. But I might have a different question: how many episodes of bacteremia were there? And maybe one person had 3 episodes, a different person had 1 episode. So this is for the pharmacy, the focus is the patients, first isolate only, because I want to do empiric therapy predictions. But from an infection control perspective, sometimes we do want to track the episodes and the clones over time. Okay. So I will do the CLSI recommendation by patient, first isolate with antibiotic results. I click OK. I click on begin analysis. And I see there were 86 isolates of E. coli from 71 people. I didn't mention this, but there were 32 patients with Pseudomonas from 31 people. So one person had Pseudomonas twice. So E. coli, 15 of the isolates were repeats. So this is a lot cleaner, and this is what we would call the traditional routine antibiogram. I'll continue that. Now I want to show you this feature called macros. I'm clicking on macros. Normally there are a lot of macros here, but when you're starting with macros, it's empty. I click on new, and I want to call this a name. I want to call this gram-negative antibiogram. It's a simple description of the analysis that I just did. I want to save all of the details. So I click on save to save the name of the macro. I click on save again to save this as a file. And now I have an option here called the gram-negative antibiogram. You don't need to look at these. It's WHONET knows what it is. You don't need to look at these, but I'll show you what it is. I'll go to edit. I can see the sun's a problem. I have trouble seeing my mouse. Edit. You don't need to look at this, but it is very simple. I want to do a percent susceptible summary with all the antibiotics, minimum of 20 isolates. Adam, I don't see the minimum here. This might be something that we need to put in. Okay, so just
It's a
check into
default
that.
value.
Right, but if the person changes it, we want to save what their change is.
Yes, if it's changed from the default, that's how WHONET typically
That's right.
works.
That is right. That is right. But it's absolutely correct. If you leave it at 20, it doesn't show up here. If you change it to 50, then the 50 would come up on the screen here. Thank you. I forgot about that.
Yep.
So this is just a little summary of the analysis that I did. I'm going to click on exit. Why did I make this macro? I made the macro for a very simple reason. Eventually, I go home and I leave WHONET. And then I come back again the next day. If I want to do another gram-negative antibiogram, I can answer the questions again. Or I can click on macros. I can load the macro. When I load the macro, it brings back all of those choices. So macros are very valuable when you want to repeat analyses over time. One of our very first webinars, almost 2 years ago, was about macros and reports. So if you want to learn about macros and reports, there is a 2-hour webinar about it. Okay. Good, so macros are there to remember things. Now I want to change this. Let me go to isolates. And let me go to specimen type. And I can say I want female outpatient urine. I can say oxycillin resistant. I can say imipenem resistant. I can say animal equals chicken. Animal equals cattle. So these are the isolate filters. I can say location equals ICU. I can say location equals farm. So I'm going to go to specimen type. I can double click on that, or I can click on define criteria. I'm going to double click. And I can say urine. I wanted urine. I can say include urine, or I can exclude urine. But I don't want to just say urine because WHONET does offer many kinds of urine. So I want to put all the different kinds of urine into my statistic. And that's up to you. We will offer a feature called specimen categories, but we haven't done that yet. So at some point, you'll be able to choose either individual urines or just choose the category urine. So there's going to be all the different urines. I say, okay, begin analysis. And you only see E. coli because E. coli is the only organism that had over 20 isolates in urine. So the Pseudomonas, the Klebsiella disappeared. And keep in mind, this is only 1 month of data. If this were 1 year of data, you'd see many more organisms. Okay, good. Let me look at the nitrofurantoin. Let me look at my denominators. And you can see 49, 49, 49, 49 nitrofurantoins. So for urine, nitrofurantoin is tested the same like all other drugs. Let me click on continue. That's a valuable analysis. Let me go to macros. I want to make another new macro, and let me call this gram-negative antibiogram urine. Save. Save again. And now I have 2 antibiograms. And then I can make one for gram-positive. I can make one for ICU. I can make one for female outpatient urine. I can choose one for MRSA. I can choose one for MSSA. So using these filters, you can do all the different data stratifications. You can also do, I'll do that example. Okay, good. I'm going to click on exit. So I have 2 macros that I can utilize later. Exit. Analysis type. Here you see variable 1 is the organism. It's a summary, and you always see the organism by row. But I also want to do this, for example, by sex. I click on OK. I click on begin analysis. Oh, okay, and they were all female. Normally, you would see 1 row for the female results and 1 row for the male results. In this particular small data set, there were no male isolates. But at least I'm showing you how it would work. The same thing if you chose, and I chose the sex as the variable. I could choose human animal food. I can choose animal species. I can choose laboratory. If I'm the national data manager, I can say I want to see my national statistics averaged together, or I would like to see row 1 be hospital 1, row 2, hospital 2. Okay, I'm going to click on continue. I'm going to say this is another macro. New. gram-negative antibiogram, urine by sex or by gender. Save once, save again, exit. So I've now shown you how to do antibiogram, some enhanced examples just by urine, stratified by adding in some of these row variables. If in your antibiogram, you don't have to do all the antibiotics, you can just do the antibiotics that you intend to put in the final report, or you can delete them later in Excel. Begin analysis, it was a tiny feature I forgot to mention. I'm going to go to click copy table. If I click on copy table and then I go to Excel, whoops, where's Excel? There. Okay, so everything is now in Excel, and you can change it however you want. Or I can save table, and let me call this this is my gram-negative negative antibiogram. This is by urine, by sex, save. Oops, wrong thing. Do you want to open the file now? Yes, I do. Yes. And there it is. So it's very easy to get the results into Excel. Okay. Now that I have it in Excel, I'm happy to see both the table and the graphs. However, it's not typical to present graphs. It's nice for you to see the graphs, but usually the doctors don't want to see the graphs. Let me just minimize this. They don't want to see all the graphs for every organism, for every antibiotic. So if you want the graphs, great. If you don't want the graphs, very easily, I'm going to click on continue, click on analysis type, and I don't have to see the graphs if I don't want to see the graphs. The final result for clinicians, we don't include the graphs. I click on OK. I'm now going to exit out of interactive data analysis, and I'm going to go to data analysis and switch over to quick analysis. So this screen has been reorganized. The first screen is called WHONET Reports for Screen and Excel. The second one is WHONET Reports for Microsoft Word and also one PDF thing. So before they were in one long list, we just wanted to, because the two lists were getting longer, we just wanted to separate the list. The Excel and screen reports have more detail. All of the organisms, all of the graphs, it's interactive, and I like these. And they're worth doing because they give you a lot of detail. But the clinicians, they usually prefer the Word version. The Word version has less detail, but it has the highlights, the top 10 organisms, the top 10 this. It has a lot of text, explanatory text. So for internal detailed purposes, you might want to do screen in Excel. For distribution to colleagues, then the Word is maybe more helpful. We are giving you these. And then here it says user defined, where you can make your own. So let me start off with, what should I do first? Yeah, I'll do the Excel screen version. We have a new one here. So many of you, I hope, are familiar with 1, 2, and 3. Those we've had for a number of years. So I'm going to show you number 4 with the antibiogram approach. Data files, and I can choose 1 month of human health data. I click on OK. Here, this is also a new feature. In the past, you would simply click on Begin Analysis. But now you do have the ability to say, I only want urine, I just don't want laboratory 1, I just want laboratory 10, I just want the gram negatives, I just want the gram positives. So you can just do antibiogram, data files, and continue, or you can put in some of these additional filters that are up to you. That's a nice new feature. I can see this on the screen, or I can go to Excel. I'm going to click on Begin Analysis. And this is the traditional gram-positive antibiogram, number 1. I'm going to click on 2. The traditional gram-negative antibiogram. Continue. This is the antibiogram by laboratory. There's only 1 lab, so you only see TST. But if you had 5 laboratories, you would see Staph aureus 5 times, 1 for each lab. So the gram-positive antibiogram by lab, the gram-negative antibiogram by lab, By gender, male and female, gram-positive. By gender, male and female, gram-negative. Age group, we don't have sufficient. It needs 20, and we don't have that many in this 1 month of data. That's by age group. That's also by age group, gram-positive, gram-negative. This is by inpatient, outpatient, gram-positive, inpatient, outpatient, gram-negative. This is by specimen category, urine, sputum, blood, gram-positive. Urine, sputum, blood, gram-negative. This is the detailed report for Staphylococcus aureus. I'd like to start here with number tested. And for the gram-positive, I see they test every antibiotic every time. I can also see, for example, clindamycin 3 times. We have the human breakpoints and the dog breakpoints. In fact, in this particular example, they're the same breakpoints. And we have the ECOFs. So because I'm using the new tables, I can see it's 14% resistant, 14% resistant, 85%, well, actually a better comparison, it's 85.5% susceptible. By the clinical breakpoints, it's 85.5% susceptible or wild type by the ECOFs. And other times the breakpoints and the numbers will be different. So here, 15 to 20 is the intermediate range, but the wild type is still at 20. So they do agree in this particular example, but in this one they don't. So for example, if the number is 16 millimeters, it is considered to be clinically susceptible. But 16 millimeters is not considered wild type. It's a little bit resistant. Okay. And good, continue. This is the same thing now for the gram-negatives. And you see ampicillin 4 times. Humans, cats, dogs, ECOFs. And here, we haven't labeled it yet, and we'll do it eventually. Here you see ampicillin 4 times in the graph area. And you know which one is which by the table. This is the human breakpoints. These are the cat breakpoints. These are the dog breakpoints. These are the ECOFs. Continue. This is the same thing for Streptococcus pneumonia, but we did not have sufficient data. And that's that. Good. Good. That I've shown you the standard screen Excel antibiogram report. That's new since about 2 months. And now we have the new Word report. So first I'll do what time is it? 8:47. We're still good on time. I'm going to epidemiology report that I hope many of you know. We've had this for about 3 years. So first I'll do this antibiogram report. I think it remembers the files. Yes, it remembers the files. Good. And I click on Begin Analysis. So this is a valuable Word report, and you can see in the lower left, it's doing a lot of different diverse analyses. Right now it's doing country by year, by month, laboratory by specimen year. So it's doing isolate statistics, patient statistics, resistance statistics, organism statistics, important species, invalid data. Well, at the top, you see number 1 is the epidemiology report. Number 2, test practices and quality. This, and WHONET will tell you, age 80% complete, gender 90% complete. Vancomycin disc for Staph aureus, no breakpoints, not a valid test. Klebsiella susceptible to ampicillin, possible result, but it's not. WHONET will never say it's wrong. WHONET will say you might want to double check it before reporting it to a clinician. The antibiogram report I will show, that's new, and that's all of these different stratifications. FAO report, we started that a few years ago, but we never finished because they said, John, thanks, but we need Infarm. So we stopped working on this FAO Word report because Infarm was needed. So we jumped over to Infarm. Now we're going from FAO Infarm first year. We're now incorporating second year. And we're going to be giving a training course in Bangkok at the end of July for animal health laboratories in Asia Pacific. We had similar ones last year for Latin America in Colombia and Africa in Zambia. So FAO is starting with an initial one in Thailand in a few weeks. Once Infarm is ready, then we can come back and finally finish up the FAO report. The last one, ASM pertussis, we do that for an American Society of Microbiology project funded by the CDC. This number 5 is not a WHONET report. It comes from, okay, the analyses at the bottom have finished. It has finished all those analyses. It is now making the Word document. Okay. Number 5 here, we did not do this. This is a software called AMAS, which is made by the Oxford Clinical Research Groups, especially in Thailand, also Vietnam, Cambodia, and Laos. So it's a PDF document, and we've had a nice collaboration on, we've learned from them. Their software can do things like mortality, admission, but if you have the data, many people don't have the data. So it's a nice feature that we utilize their tool to generate a PDF document. Okay, good. So now it is still working on the Word report, and it's now working on the WHO GLASS. After this, it still has, I think, 2 more sections to do. Oh, what else can I talk about while it's doing this? Okay. Oh, it's now doing outbreak detection. That is about WHONET SAT scan for looking for inpatient or outpatient outbreaks. We also have 2 webinars about WHONET and outbreak detection. If you have an interest in that, look at our webinars page. It's now on the last page of the antibiogram and now just finished. I have finished. Do you want to open the file now? Yes, I do. Usually that report on my computer is faster, but my computer sometimes gets tired. Okay, so here's the Word report. First, I'm going to zoom out so you can see there's a lot of graphs and tables and figures and text that I will not talk about now. We talked about it in a different webinar. But the last page of this is the traditional antibiogram. Gram positive at the top, gram negative at the bottom with a legend. The same thing that I showed you on the screen. So we've offered this routine antibiogram for a number of years. I'm going to close out of this. Okay. I could show you number 4 antibiogram, but I think just for time, I'm just going to jump over to the Word version. So Word antibiogram. I'm going to click on Begin Analysis. This is a first version of it, so we'll be making refinements and more text. A lot of the comments that I made during my PowerPoint, we would like to put into the antibiogram report so that the caveats and the limitations are also available. So this Word document is our first version of this Word document, and of course we welcome your input and feedback on how we can make this more valuable and better. So the difference is that the epidemiology report did a single gram positive, gram negative antibiogram. This Word report does it by gender, it does it by laboratory, it does it by specimen type, does it by age group. So it does a lot of these different data stratifications. It does not yet do MRSA and SSA. There are certain things that we plan to do, we just have not implemented yet. Adam, can you, oh, okay, good, it's finished. But Adam, if you could start looking at the questions in the chat box. Okay, do you want to open the file now? Yes, I do. So one annoying thing that we've tried to do is that the file is now open, but I don't see it. Where is it? I have to go down to the bottom and click on the Word icon, and there it is. So this is the antibiogram report. Okay, good, and I'll start at the top. So number 1, this table 1, traditional gram positive. Table 2, traditional gram negative. Number 3 is by laboratory. Number 4 is gram positive. Number 4, well, I won't say number because I'm not looking at the numbers. By laboratory, by male and female, by age group, if you have that information. And here it says no results because it was under 20 isolates. And here we have inpatient and outpatient. And then we have the E. coli and the Haemophilus. And then no results here. So this is our first version of the Word report for the antibiograms. I'm going to stop the sharing screens. And Adam, are there any questions?
There are a few, yes. Let's see.
Okay, I'm starting to look down, and I'm not going to complain about having a nice, beautiful day here in Boston. It does make it a little bit hard to see my screen.
Okay, the first question I think you should look at, was it 836?
Okay. How to add antibiotic organism panels of your own choice, like Acinetobacter? Yes, I see that. Okay, I'll share my screen. There are certain things you can do now and certain things you cannot do now. Okay, good. WHONET. So the question could be taken with regards to data entry or data analysis. I'll show you first with regards to data entry. Modify laboratory, antibiotics. For data entry purposes, you go to panels. And here you see staph and viridins and gram-positive and gram-negative urine. If I go over to the right, you see the fungi, the salmonella. So Acinetobacter is here. So, it's not under that name yet. So Adam, we have discussed this. Right now for the non-fermenters, we have two things here, Pseudomonas and non-fermenters. We want to break up the non-fermenters to include Burkholderia, Stenotrophomonas. When I say non-fermenters here, Acinetobacter is what we have in mind. So there are two things. We will add in the further breakdown of the non-fermenters. That's not difficult for us to do. We just hard code it. We would also like to put the ability to have a user defined. So you could say, create new panel. So that feature we have not done yet. It'd be easy to add one more column, but we need to make the connection is which organisms are associated with that panel. So I would put the Pseudomonas antibiotics here under Pseudomonas. The Acinetobacter breakpoints, the Acinetobacter antibiotics I would put here. And we will break up into the other organisms, which are less frequent. And then when you get to data entry, oh, Adam, this came up. Well, the backtrack dictionary. There must be something we did with the backtrack dictionary. So let's take a look at that another time. Most people don't use that feature, so they would not encounter that. Okay, so if I go to E. coli, it automatically goes to the gram-negative breakpoints, but we want to rename that to Antibacteriales breakpoint. We call it gram-negative because, in fact, if you don't do the other ones, for the other gram-negatives, it will default to this one. That's why we called it gram-negative. But to align with CLSI and UCAS, we will rename gram-negative to Antibacteriales. But you can always change it. For example, if I put Stenotrophomonas multifila, it goes to the non-fermenters, which is correct. But this organism is different from Acinetobacter, so you can still choose here all antibiotics. So you can still see everything. So you do have flexibility for data entry. And then for data analysis, WHONET by default shows you all of the antibiotics that meet the criteria. But you can select the antibiotics. So for example, for E. coli, you might have 4 different aminoglycosides, but maybe you only want to include 2 of them in the antibiogram. So I can go here to browse and I can say, well, for this analysis, I just want these particular drugs and not the other drugs. And you can do the same for Stenotrophomonas. So that's how you can do that. Okay, let me go back to the questions. Adam, when is the next question? Oh, can the data entry forms be customized? Yes, they can. Good. So, okay, exit. And if I go to File, Modify, Laboratory, here is the section called Data Fields. It's all the data fields, and you can customize it in a few ways. Well, one, you can move up, move down. I want this question up, I want this question down. Not very interesting. First name is 20 characters, but I can make it 30 or 5 or 10. I can change that. I can go to modify the list, and I can start. I can put the date of discharge, the diagnosis, the name of the doctor. So you can add questions, and you can also remove questions if there's certain things you don't use, you can get rid of them. Okay. Here I can see that first name is a human question. Last name is a human question. Sex is a human and animal question. Age is human. Well, age can be relevant for animals. We don't usually know the age, so you can customize it. I was saying that first name is a human question, but for laboratories working with cats and dogs, often they do keep track of the cat or dog's name. They don't usually keep track of the name of the chicken or the name of the fish, but so you can customize it and add and remove things. For example, department, this is a location question. It says that here, location. But it can be a farm question, a treatment question, an origin. Origin means human, animal, food, environment. Microbiology question. So yes, the data entry screen can be configured. For example, here, if I clicked on animal, the questions are now animal questions. Food, they are now food questions. We're going to get rid of plant because we do not yet have guidance. Plant is interesting, but we do not yet know. We don't have any drop-down lists, so plant doesn't mean anything right now. Environmental, we do have that. Okay, Adam, what's the next question?
It should be just a little bit farther, 843.
You gave an example of a national data manager looking at multiple hospitals. Does WHONET have a current solution to get data from multiple instances into a central one for national analyses? WHONET is a desktop application. It's not a web application. So how do individual labs get the data to the national center? Some send it by normal, simple emails. We don't recommend that. It's not secure. We would not be permitted to do that in the United States because of our law HIPAA. You can send a normal email with an encrypted attachment. You can send a secure email. You can send FTP, that's secure FTP for sending secure files. Some people upload to a national portal. So for example, in Vietnam, once a month, they go to the web portal and they upload their files. Some people save the data into a secure Google Drive. Like in my hospital, we would not be allowed to do that. We can't put patient data onto Google Drive, but we are permitted to put the data onto Dropbox Business. The hospital has a contract with Dropbox Business to cover confidential data. So there are different, because it's a desktop application, there's no secure national server. It makes it much easier. Desktop applications are easier to work with and maintain. But we would also like to have a web version, but we just don't have the resources to get that up and running. Because a desktop application has to work. A web application has to work quickly or it's useless, and it has to work securely or you put yourself at legal risk. Adam, what's the next question?
849. The breakpoints. What are breakpoints?
Oh, what really are breakpoints? Intermediates. Right. So the purpose of CLSI and UCAST is not to find resistance genes, is to predict the clinical outcome. So the breakpoint says S, the patient is likely to respond to therapy. Started unless if the patient is at death's door, if the patient comes in with a susceptible E. coli with meningitis, and you give the patient antibiotic, and the patient dies 20 minutes later, that's not resistance. That's a late stage presentation. The antibiotic did not have enough time to work. So susceptible means that with appropriate treatment timing, that the patient should get better and the antibiotic should help. Resistance means that patient is unlikely to get better because of the antibiotic. The patient might get better anyway because they have a good immune system, good hygiene, good, like for a lot of skin infections, what you need is soap and water. So with R means the antibiotic is probably not going to help. And the I for CLSI says we don't really know. It's sort of a buffer area. It might be a little bit resistant. The patient may or may not get better. For UCAST, I means susceptible with increased exposure, with increased dosage. Those are what we call clinical breakpoints. And then there are the microbiological, epidemiological breakpoints, which are basically to say these bacteria do not have, they have a measurement suggestive of no gene. Or there's a small decrease in the zone diameter. There's probably a resistance gene, but because of the high dosing in urine and the concentration, it's not a serious disease. It might be clinically susceptible, but still microbiologically resistant. The next question, the system isn't displaying pending users as it usually does for some reason. I was able to let you in by search. Oh, I'm sorry, Adam, you wrote that to somebody. That wasn't a question, sorry. Adam, what is the next question?
901, I think.
And for those of you who have to drop off, feel free, and everything will be available online. How do I convert my data needed to be entered into WHONET? So if you manually enter the data into WHONET, like I was just showing, the data are in WHONET. But if you have a Vitek machine, a Microscan, or a Phoenix machine, if you have Excel, if you have a laboratory information system, we don't want you to retype the data. Put the data into your system every day. And then once a week, once a month, once a year, at the end of your project, send the data to WHONET. And that is done with another software we have called Backlink. We have done webinars on Backlink. There's Backlink and Vitek, Backlink and Microscan, Backlink and Excel. There's a veterinary LIS in Africa called CLab. So you would need to look at our website at the Backlink training materials. Am I still sharing my screen? Yes, I am. I'm going to whonet.org. And if I click on Training Center in the top menu, you'll see a lot of WHONET resources here, followed by Backlink resources. So I would suggest looking at, Backlink getting started, and then Backlink from Vitek, Backlink from Cerner, Backlink from these different systems, and Backlink from other systems, etc. So that would be that. Okay, good. Adam, the next question.
I think it's just the next message down.
Implementation of username and password authentication. Are we going to expect this soon? I also noted there's an antibiogram attached now on the EPI report. Is this also the same with the one in quick analysis? Well, the epidemiology report has always had an antibiogram as the last page. That was always there. The new report called Antibiogram, that's very new. We just added, I think, on the screen about a week or two ago. So that's why you see the tables, but there's no text yet. Regarding username and password, it's something, so we started a web version, and the web version does have username and password, because for web, that's essential. If everything is open to the world, it has to be secure in every respect. For desktop application, we ultimately rely on Windows, Microsoft Authentication, a Windows username, a Windows password. We have thought about putting in username and password, and that could help some things, but people still might go behind the scenes and go directly to the data files. At the present time, we don't protect the data files. They're protected in the same way your Excel and your Word files are. They're on your computer in a password-protected computer or server or folder. So it's a feature we'd like to offer. We'd also like to offer, and we did this for a CDC project years ago, for auditing. Who did this at what time? What did they access? So a timestamp of user interactions. We'd love to do those features, but we're such a tiny team with a lot of diverse commitments and responsibilities. So it's not a current priority just because we have so many other things that people are requesting. So for our Windows WHONET desktop application, we rely on the traditional Microsoft approach. You protect your computers, username, password, you protect your folders. You can go to a folder, you can do this yourself. You just go to a, let's see, document. If you right click on something, you can go to the advanced properties and you can do what's called read-write protection. You can protect the folder so non-authorized people can't get into that folder. You can protect a file so non-authorized people cannot open that file. You can give read access. For example, you might give read access to the pharmacy, but you might give read-write access to the laboratory people. The pharmacy people have a lot of interest in analyzing data, but they should not be the people editing the data. That's a laboratory responsibility. Okay, how can one recover lost data from WHONET? It depends on the reason. If it's a virus, a theft, damaged computer, we can't fix that. It's just like any document. So the first thing, before I talk about protection, is make sure for any important file, WHONET, Word, Excel, PowerPoint, anything important, have a backup strategy. Because things get lost and damaged, and we can't help with that. I'd like to save in a hospital or in a laboratory setting. I like to save the data onto a network drive for two reasons. On a network drive, many people can share it. The pharmacy, infection control, infectious diseases. So that's convenient. You don't need to send them the files. They have access. You just give them permission to use it. That's one advantage of the network. The second advantage of the network is hospital or laboratory. I say hospital, but I mean any laboratory, like public health lab, veterinary lab. The IT people are usually pretty good about backing up the server. My hospital, we back up every day, maybe multiple times a day, I don't know. Other people are pretty good about weekly backups, monthly backups, and not great, but it's something. So backups, the main strategy is to make sure you have a backup copy saved. Okay. Sometimes, now regarding if the data are lost, sometimes the data are not lost. Sometimes they're in some folder that this person saved the data here, this person is looking in the wrong place. Sometimes and often we can find those data. We do a search. WHONET files end in the letters SQ by default now. Use SQLite, SQLite. So we'll do a global search. Are there any SQLite files on this computer? So there are different, it depends on what the reason is for the loss. And sometimes it's not a loss, but we don't know where the data are. We can help you to find the data. But if the data are damaged, it's same thing with a Word document. If you have a corrupted Excel, there are certain things you can try. But there's not the best thing is to save up your data and back it up. How about an iOS installer for WHONET? iOS, Adam, does that specifically mean Apple or?
Yes.
Yeah, okay. WHONET, we've made a lot of progress towards a non-platform independent version of WHONET. WHONET was made for the Windows world, but we use a software, Visual Studio .NET, and starting with version 5, in theory, it can do Windows, Mac, and Linux. And a lot of the WHONET backend is compatible with Mac and Linux. But the WHONET front end is written in WinForms, which is only for Windows, obviously, and there's no migration. So for us to go to Mac, we're going to have to rewrite all of the interfaces. The back end we need to improve, but all of the Windows interfaces need to be changed. And with a small team, it's not something we can do right now. We've made progress in that direction, but not actively working on it. Having said that, many, many, many people around the world do use WHONET on a Mac. I'm going to go to Windows. I'm going to go to Google. And if I just ask Google, how do I run a Windows application on a Mac? To run Windows applications on a Mac, you have several options, and then you can look at these in more detail. There are a couple of approaches. So yes, many people run WHONET on Mac, but the Mac needs Windows. One way to do this is a partition. Like 95% of your computer, the hard drive can be Mac, but 5% can be Windows. So that is Windows. It's a Mac computer, but 5% of the hard drive is reserved for Windows. So that's one way to do it. It's called a Windows partition. You can also make a Windows virtual machine or a Windows emulator. There are different softwares that do this. So WHONET does run very well on a Mac, but basically you need to install WHONET either as a partition or an emulation or a virtual machine. And if you have further questions, you can contact us. You can also do one of these searches. All of these have nothing to do with WHONET, but all of these resources do give guidance about how to run Windows computers on a Mac. Okay, Adam, other questions? Okay, and Mowgli, I'll look at the help to get back to you on your question in the help inbox.
I think that's just about it, actually, for the questions so far.
Okay, excellent. Adam, when do you think we might have the video up online?
It should be available, sometime later today, maybe within the next 12 hours or so.
Okay, great. Okay, I'm going to stay on the call for a bit, so feel free to post more questions. If you would like us to unmute, and if you'd like to ask a question that way, that's also fine. But thank you all for your time. I hope it was a useful session. Thank you all for your work in human, animal, food, and environmental sectors. And we look forward to, we haven't decided the topic of the next webinar, and we're open to suggestions. Thank you, everyone, for the thanks that are popping up.